em- emerging concepts in COPD. Welcome, Dr. Mannino.
Thank you, Raphael. Yes, I'll be talking today about some of my favorite topics. So some of these are actually what I'll be talking about today. Some might consider rather controversial, but that's okay. We'll move forward with it. And what we're really attempting to do, as you'll see as we go through here, is really sort of change the landscape in COPD. So with that, if I can figure out how to advance my slides here. Okay, so these are my disclosures, and you'll see I do consult with some pharma companies who are attempting to develop new therapies to treat COPD, and also I continue to serve as an expert witness on behalf of people that are suing tobacco and vaping industry. So these are the three main areas I will be discussing today, and all of these are both groundbreaking and some might consider a little, somewhat controversial, maybe with the exception of that final one. But certainly how we sort of explore these various concepts is going to be important, particularly for you younger folks out there who are just sort of getting started in looking at chronic respiratory disease. And we're going to start sort of going back in time. This was much earlier in my career, and this is sort of like a pictorial view of how the American Thoracic Society's guidance, from the 90s, which is now almost 30 years ago, viewed COPD. That basically, and they had the overlapping circles of chronic bronchitis, emphysema, asthma. And if a person had either chronic bronchitis or emphysema and had evidence of airflow limitation, this was considered COPD. And this is actually a concept that goes back to Dr. Charles Fletcher, who's a British physician, who put together a symposium looking at chronic lower respiratory disease in the late 1950s. And this was, and this sort of really has its history, based in that, because this is really a continuation of that type of concept. GOLD, which amazingly is now over 20 years old, and we just actually had our GOLD conference, and GOLD is a global initiative on chronic obstructive lung disease, and just had our 2023 meeting with the update that will be the 2024 update earlier this week. But they sort of had a different sort of concept of sort of expanding what comprised chronic obstructive lung disease, and that was sort of expanding beyond just people with chronic bronchitis or emphysema, but anybody with evidence of post-bronchodilator obstructive airflow limitation. Now, and again, they actually received a great deal of criticism at the time, because others acknowledged, well, not everybody with obstructive airflow limitation has COPD. In fact, most do, but there are some that, in fact, do not. Since then, other types of criticism, including from me, for example, I'm not a.
Oh my God.
To be documented post bronchodilator. In any case, as we move forward yet again, COPDGene developed and published in 2019 a very different, sort of an expanded concept of what comprises COPD. And this was based on some of the data that they had evaluated in the COPDGene project. And there are a couple of sort of key different concepts here. One is that they included both this restrictive airflow limitation in addition to obstructive airflow limitation as being a potential means of identifying COPD. They moved from from the concept of diagnosed chronic bronchitis to symptoms of either chronic bronchitis or dyspnea, which is one of the cardinal symptoms in COPD. They moved from emphysema to radiographic findings of either airway thickening or radiographic emphysema. And most importantly, they then sort of had this opportunity to have either possible, which is the latest shading here, probable, or definite COPD. And I think this was a clever way of sort of dealing with some of the criticisms that, well, not everybody with obstruction, not everybody with restriction, in fact, has COPD, which is absolutely true. That there are other explanations for these spirometric findings, but as one sort of stacks up, both radiographic changes and symptoms and the spirometric changes, you move towards a more likely diagnosis of in fact COPD. And this is now what we call the COPD diamond that looks at these four components. And because COPD was all limited to current or former smokers, that was their main exposure. But certainly, I think others looking at this have expanded this to include occupational exposures, environmental exposures, biomass smoke, and the like. So I think this is can certainly be expanded. But basically, it included this, the facets of the diamond of abnormalities on imaging. And here, this was more than 5% emphysema on CT scans, or airway thickening, or evidence of air trapping, symptomatology, and then spirometric changes. And if a person had one facet of the diamond, because everybody in COPDGene was exposed, and that was basically the floor, although one could applying this to other populations. There's some projects that I'm currently working on that's trying to validate this type of approach in other populations. And if you have two facets, that would be possible COPD, 3 probable, and all 4 would be definite. And this is a shows some of the pathways that had been demonstrated in the COPDGene data, and this was really sort of one of the the drivers of this type of paradigm. And the concept here is that, and if you're not familiar, and we have the FEV1 as percentage of predicted is plotted on the x-axis with the FEV1 FEC ratio on the y-axis, and traditional COPD based on on a obstructive spirometry, the FEV1 FEC of less than 0.7 would be everybody sort of below the that horizontal line at 0.7. Clinically significant COPD would be that lower left-hand quadrant. And then the concept here is that people sort of start out in that upper right-hand quadrant, but there are different pathways to how people develop COPD. With the blue pathway up top being people that develop more airway issues initially, be this asthma, and these are people that may actually sort of go through a restrictive, or what COPDGene calls PRISM phenotype on their way to develop more classic obstruction, whereas the pink pathway are people who develop more emphysematous type changes, and actually where their FEV1 FEC ratio drops, and probably a more traditional view of how COPD develops. But I think what the COPDGene project has demonstrated is that both of these pathways actually exist. And as we say, the proof is sort of in the when one looks at outcomes. And I think this was one of the key components of this paper, is that they validated this type of approach, looking at important outcomes. And these would be accelerated loss of lung function. So this was an estimate over 5 years, for loss of lung function of at least 350 mils, which would be accelerated. That's at least 50 or so cc's per year, and then the all-important outcome of all-cause mortality. And one could see, as one moved from possible, probable to definite, and there was not only an increase in loss of lung function. They didn't quite hit statistical significance for mortality, but it came close. You could see there. But there's also evidence of a dose response. So, the higher one moved up the scale, those odds increased. And if one, and this sort of then goes back to this paradigm again, as we look at additional outcomes. And I think what was important here, for example, is in evaluating people that would be considered normal under GOLD. And you could see that it was like the majority was over 50%, that I think I have on the next slide, of patients in COPDGene at their baseline evaluation were considered normal. Yet under the COPDGene classification, the majority would be either as possible, probable, or definite COPD. Now, as one would expect, as you moved into the traditional GOLD categories, that by definition had obstruction present, a higher proportion would be probable or definite COPD. So this was, I think, reassuring. But if one looks then at outcomes, so as I mentioned, this was under the GOLD definition, the majority of patients in COPDGene at baseline are normal, whereas under the COPDGene classification, less than 20% now are normal, with almost equal division between definite, probable, and possible COPD. And if one looks at the outcome of mortality, and this is what I focused on here, was people that were considered normal in both by the GOLD classification and COPDGene at year 11 of the COPDGene follow-up. A higher proportion of patients meeting that were normal under GOLD died relative to those that were normal under COPDGene, suggesting that I think this sort of reclassification that we saw with going to COPDGene is in fact identifying people with earlier stages of abnormal lung function. And the reason I think this is important is displayed in this diagram here from Chris Cooper and Mark de Kramer. And the problem here is that if one looks at how COPD develops, by the time we find physiologic abnormalities such as impaired lung function, and we're already dealing with fairly advanced disease, and the spirometry may not be terribly abnormal, but physiologically they are well advanced. Because we now have evidence that things such as radiographic abnormalities and certainly the biochemical and cellular events are happening much earlier in the process. And if we're going to make a difference in COPD, we really have to sort of move this paradigm and get and find people at a much earlier stage. And this then has sort of raised the concept of pre-COPD, and then we have this by analogy in other disease states, just pre-diabetes, pre-hypertension, and this is sort of finding people in the very early stages of disease. And in fact, I think that there are some people in that possible COPD category who in fact have COPD, but others then would possibly be characterized as pre-COPD. And this is a concept that we're still actively investigating. So with that, I'm going to move to the second component, and this was based on a paper that was published in Lancet Respiratory. Actually, it was Lancet, last year, with Diana Stoltz from Switzerland and Germany being the lead author, but also then I think an impressive collection of co-authors from around the world trying to tackle this problem. And this is this is sort of like a different version of that diagram that I showed you a couple of slides ago. A up the top is where we currently are. By the time we diagnose COPD, people already have had symptoms for a period of time, and their lung function is significantly impaired. And we're basically dealing with managing symptoms, because all of our current therapies really do nothing more than manage symptoms. And where we need to be is in B down the bottom, where we find evidence of COPD while lung function is still preserved, and we can actually intercept disease and preserve lung function before disease becomes advanced. And you'll see that at the far end, at age 80, if this paradigm works, and we'll have people with preserved lung function, as opposed to what we currently have as people with basically destroyed lung function. And part of the another concept that's introduced in this is that of what are called etiotypes. And this was something that was actually borrowed from other parts of the pulmonary world, mainly pulmonary hypertension. And the concept here being that there are different etiologies of COPD. That certainly in high-income countries, the one that we are most familiar with are, in fact, the exposures of tobacco smoking, but also occupational and other types of exposures. But there certainly are genetic causes, alpha-1 being the most well-known, but there are certainly other genetic causes, early life events. Things that are happening either prenatally in early life, and some of these are infections that are also sort of covered in other areas, or exposure to air pollution. The role of infections, and certainly in low and middle income countries, infections like tuberculosis are important. But I think even in higher income countries, there are other sort of acute or chronic infections that probably play a role in the development of COPD. And this is sort of a busy slide that I'll also then be breaking down in subsequent slides. But this looks at what happens through the lifetime, including developmental abnormalities early in life, environmental exposures throughout the life, and then issues related to aging, and all these are important. At every life stage. And if one looks sort of epidemiologically at where people are classified, and there are some people who have persistently high lung function, others have had persistently low lung function. Of course, most people are in the average, but there are some people with accelerated decline, and some people actually have growth. So in subsequent slides, we'll look a little bit at this. And this is a classic study that's now unbelievable, almost 10 years old. That looked at Peter Lange looked at data from several different cohorts, looking at how lung function changes. And if one recalls the original Fletcher and Peto diagrams of lung function decline, really focused, according to them, everybody sort of started at 100%. and we know that isn't true, that there are some people, because of developmental issues, never really reach what should be their maximal lung function. And those would be the blue and yellow lines. And of those that do recently reach the maximal lung function, there are some that sort of have accelerated decline. That would be the red line. And these are also important trajectories as we try to really unravel what's happening in lung disease at every stage of life. So this now goes back to that, the top part of that diagram, looking at various exposures or modifiers at different points in the life stage, both in infancy, early life childhood, through early adulthood, and then on to late adulthood. And these are, in fact, what some of those potential exposures look like. We know, for example, now that smoking in the preconception period can affect lung function after birth. Issues related to nutrition and allergic predispositions, early life infections can affect both fetal life and early life. And of course, in our as adult pulmonologists, most of our focus has been on exposures in adult life, and these include occupational exposures, air pollution, smoking, and the like. And this then sort of relates to down the bottom, the different phases, how the lungs develop, how they continue to grow through early adulthood, the plateau, and then the decline that we all have in late adulthood. So this puts it all together back into one slide. And I put this in here, and this is sort of like the proposed diagnostic algorithm, that these that this commission put forward. And I think an important component here is that it's recognizing the importance of imaging. And in many parts of the world, it's actually easier to get imaging, either CT scan, certainly X-rays, than it is to get a spirometry. And I think we are seeing, certainly on the COPD Foundation social site, we're seeing the increasing number of individuals who have evidence of COPD first identified based on imaging. So this is a interesting development, and it's something that I think we need to acknowledge and perhaps take more advantage of going forward. But certainly, if you sort of go through this algorithm, there are that things start with symptoms. We currently don't have recommendations for screening for COPD, at least using spirometry in the U.S. Although, and this is a field that's starting to change rapidly. I've worked with a project called Capture that's looking at questionnaire-based screening, and in addition, as more and more people are having CT imaging for lung cancer screening, I think we're seeing other morbidities that are emerging from that, including COPD, in addition to heart disease and muscle wasting, osteoporosis, and the like. So this is an area to stay tuned. But as one sort of moves down this diagnostic algorithm, there are different ways to getting to a COPD diagnosis, including, of course, spirometry, but also alternative testing. And then they have other techniques here, including oscillometry, which has been around for years, but I think now with the wonders of modern computing and artificial intelligence may be sort of circling back into our diagnostic paradigms. And this was another sort of component of that of the commission paper, and it looks at how drug development in COPD has lagged. that compared to what's happened in cardiovascular disease, where there continue to be major advancements. In the world of COPD, although up to 2019, this may look impressive, that pretty much all these therapies were bronchodilators and some inhaled steroids, most of which have been around for many years. They were just new combinations. Now, it's the hope that this diagram will be changing, because in the pipeline there are currently some biologic therapies that are looking rather promising in COPD, along with a new inhaled therapy called ensifentrine that may be showing some promise. But I think the hope is that this diagram will be changing dramatically in future years. One of the problems is highlighted here, and this looks at the metric of NIH expenditures relative to deaths from various diseases in the US. And you can see the exception here is that chronic lower respiratory diseases have the lowest amount of NIH expenditure per death relative to other diseases out there. And this is something that we've been aware of for for years, and keep talking to NIH about, and keep pushing for change. It's challenging, but and look at deaths from COVID, for example. Although more deaths in 2020, those deaths have dropped dramatically, although funding continues to be at a relatively high level. Alzheimer's has been a success story in terms of funding, and we would like to see chronic lower respiratory disease, which is mostly COPD, get at a similar level. So these are the very these are the goals that were put out by the Lancet Commission, and I think these are aspirational. But I think you aim high. For example, to eliminate exposure to smoking, vaping, hookah in more than 50% of countries, and this is, and there are a couple of countries that are moving in this direction. The U.S. is not one of those, but I think this is a great goal to aspire to. Paying more attention to environmental exposures, particularly particulate matter pollution. There's a consistent link around the world between social determinants of health, particularly poverty, and obstructive lung diseases. And that, I think this relates to a lot of these developmental abnormalities. And this is another aspirational goal, along with increasing vaccinations. Finding more people early in the disease course, and of course, to do this, we need tools and better biomarkers. Most of our clinical trials currently focus on people with late disease, and we need to change the paradigm here to focus on people with earlier disease. Introducing this concept of COPD subtypes in our current ICD classification. And again, they were successful, here when looking at pulmonary hypertension. So that's something we can aspire to. And then using these subtypes to better develop certain specific pharmacologic therapies. And then better managing and controlling COPD with fewer exacerbations, fewer symptomatology. Having clinical trials that focus more on patient-centered outcomes. I yet to have a patient come in complaining of a low FEV1. That is the primary endpoint. So we have no outcomes that have really looked at dyspnea, for example. And then using these other outcomes to get therapies approved and increasing funding. And this is from the foundation that these sometimes what are currently barriers may well be opportunities. So, for example, various risk factors, how these can be mitigated, and also sort of increase awareness that anyone can get COPD. It's not just smokers. Moving towards earlier COPD, getting better targets and therapies that focus on patient-centered approaches, and then newer designs for clinical trials. For the final component of what I'll be talking about today, I'll be talking about what has been a new term to me. I was not familiar with this until just a couple of months ago, and that's the term of syndemics. And these are synonymous epidemics, or the occurrence of disease clusters with shared risk factors and interactions that have an important burden on society. And certainly, and the concept of COPD and multimorbidity or polymorbidity is something that I have been focused on for many years in my career. But in going back to this work, which is now almost 20 years old, which was attempting to answer the question in a longitudinal database, what do people with COPD die from? And so on the x-axis, these are rates per 1,000 person years, and you can see that people with normal lung function, die at a much lower rate, about 1/10 of the rate of people with severe COPD. But even amongst people with GOLD 3 or 4 COPD, so FEV1 less than 50%, in this one, it was only about 25% or so that were dying of COPD, and that you had people dying from heart disease and lung cancer. And if you looked at people with milder impairment, for example, just go up above that to GOLD 2, it was less than 1 in 10 people that died of COPD, with the majority of deaths being from heart disease and lung cancer. So this then sort of led to a sort of a line of work that I continue to pursue for many years. For example, this looks at, what is the risk of incident cardiovascular disease. This would be an acute MI, heart failure, stroke, in patients with COPD. And you can see, with each, as one increases in COPD severity, and I also included the restricted or prison group here, that the risk of these events, and these are people that had no disease at baseline. So keep that in mind, because on the same scale, what happens with people who already had existing cardiovascular disease? Well, you see that same increment, but now it's much higher. If you sort of go back, here it sort of peaks out around 40% at 15 years. Here it goes up to 80% at 15 years. And another way of looking at this is what is the prevalence of cardiovascular disease and at different stages of lung function impairment. And here, relative to normal, it's increased in every COPD group, including the GOLD zeros there. Hypertension, similarly increased, but not to the same extent. But if you sort of look at various outcomes, and this looked at diabetes, hypertension, and cardiovascular disease, compared to normal, this then looks at the increased risk of death. That if you had severe COPD and all those comorbid factors, and your likelihood of dying at the end of this study was nearly 30 times higher than a person who was normal lung function with no comorbid disease. So, and when you look at risk of hospitalization, this was within 5 years, and you see a similar stair-step approach. So this highlights how important comorbidity is in thinking about COPD. And this then looks at other sort of important comorbid diseases, and this looks from 2 different studies, one from Loewe van Vletteren from Sweden, and Weldivo from Boston, and showing that when you look for this, you find it. And this is sort of another way of looking at this, concept that, and I think, we in the pulmonary field have been guilty of siloing. We sort of focus on on COPD, but it's hopefully that we'll be able to change this, particularly as we sort of as I have some subsequent slides, looking at how we might better address this concept in the future. The Lancet reports love these life course documents. So here is another one, looking at going from pre-birth to through pregnancy, through development and aging, with different exposures. And down the bottom, I think this was an important concept, that there are basically 6 pathways to, in disease development, and they're sort of listed here: fibrosis, apoptosis, immune response, thrombosis, inflammation, and cell proliferation. That all disease processes can be reduced to these. And for example, if one looks at the 2 cardinal or traditional subphenotypes of COPD, that emphysema is sort of goes in one direction, and bronchitis goes in the other direction, with different sort of biomarkers pointing you in each of those directions. And you can see the other components of polymorbidity that are in that comprise those subtypes. And of course, people can have kind of all of these, so that's key to think about. And this sort of is another means of looking at polymorbidity in our COPD patients and how these can be assessed. And we had talked a little bit about imaging, and also there are other sorts of markers, and imaging seems to occur in multiple ones here. And this is the ultimate sort of concept where we would like to go, going from multiple single disease guidelines to more of an integrated polymorbidity management. And an area, for example, that I am particularly interested in is the interaction between what's happening with the lungs, what happens with the heart, and how we pharmacologically manage COPD exacerbations. For example, our current therapy of exacerbations utilizes lots of inhaled steroids and bronchodilators, and it's possible that that these may be an important factor in the development of acute events following exacerbation, which are mostly cardiovascular. So, so I'm involved in work that looking at how we might be able to limit large exposures to bronchodilators in our COPD exacerbating patients. So, some of the other emerging concepts, as I just mentioned, do we need to think about these cardioprotective strategies in exacerbation of COPD? And this is an active area of research that I'm involved with. Will different types of inflammation be drivers of therapy? And I think some of what we're seeing with various biologic therapies and COPD is focusing on this. And then finally thinking about these other sort of treatable traits and how they may direct therapeutic decisions, particularly in the context of polymorbidity. So to finish up, there are a lot of layers of complexity in COPD that extend just beyond the physiologic airways. And if we're going to do a better job at preventing COPD, we really have to rethink and move back far earlier in the process. The aspiration goal of eliminating COPD will involve multiple strategies in both high-income countries and LMICs, and hopefully with the benefit of looking at other chronic diseases. And then this new term of syndemics is critical in our ultimate approach to COPD. And I end all my talks with this parting thought: COPD is preventable and treatable. And with that, I think I have left a couple of minutes for questions. So